Hello everyone, thanks for joining us today. We are live now. Hisai, over to you.
Thank you. 皆様、本日は、SI-UK ウェビナーにご参加していただきましてありがとうございます。本日はですね、国際的にも知名度の高いシェフィールド大学をお招きいたしまして、公衆衛生学というテーマでお話をしていただきます。まずはクレアさんの方からシェフィールド大学の内容についてご案内させていただきます。Claire, could you start your presentation, please?
Okay, thank you. Okay, hi, I'm Claire Beecroft. I'm the Deputy Director of Learning and Teaching at SHAR, the School of Health and Related Research at the University of Sheffield. So I'm going to start today by just talking briefly about the programs that we offer at SHAR and a little bit about SHAR as a department and Sheffield as a university and about the city. And then I'm going to hand over to Dr. Sam Catton, who's going to deliver a short lecture introducing the topic of public health to give you a sense of the subject area that we offer our courses in. So we offer both online and campus-based programs at SHAR. Our online programs are our MPH in International Health Management and Leadership, our MPH online program, and an MSc in International Health Technology Assessment, Pricing and Reimbursement. So those are fully online degree programs. So for these courses, you don't have to come to Sheffield at any point. They are delivered fully online, and you can study for an MPH or an MSc, or you can also register and do postgraduate certificate or diploma qualifications as well. So I think mainly we were going to talk about our campus-based programs today, but I thought it was worth mentioning that we do have 3 online programs, and these are all part-time study programs. So you can do these online programs whilst continuing to work full-time. But in terms of our on-campus programs, so these are the programs where you travel to Sheffield and study with us on campus. We have an MPH. MPH just stands for Masters in Public Health in Management and Leadership. We have our standard Masters in Public Health program, our Europub Health program, and then Masters programs, MSc programs in Human Nutrition, Health Economics and Decision Modelling, and Clinical Research as well. So we have quite a broad range of programs in SHAR, but overall our subject area is public health, and I think most of you today are probably interested in our public health programs. But again, we do have quite a range of subject areas that we teach in that are all related to public health, all of which have different career options that might lead from them. And for those of you, I think some of you will probably have already booked for the careers fair on Saturday. But if you haven't, if you are, sort of unsure if you're interested in potentially, more than one of our courses, or you just like to know a bit more about the wider range of courses we offer in SHAR and what the career opportunities are that lead from those, do register for the fair. Myself and Hannah will be there on Saturday, so you can book an appointment one-to-one to have a chat with me to talk about which course option might be the best one for you. So what's it like to study at SHAR? Well, SHAR is based in Sheffield, so hopefully you can see this little map of the UK, and the little red pin is where Sheffield is. So we're in the north of England, kind of southernmost part of the north of England, if that makes sense. So we're very near to other major cities as well. So it's a good place to come to study if you want to do a bit of exploring and to sort of really kind of immerse yourself in your time in the UK, because you can get to London in a couple of hours from Sheffield on a train, but equally we have Liverpool, Manchester and York, all major UK cities that are all within an hour really of Sheffield on a train. So if you're interested in exploring a bit, while you're spending time in the UK, Sheffield is a fantastic base for that. Obviously, cities like Manchester and Liverpool are very kind of modern cities, whereas York is extremely obviously historic. So it's a really good place to study and for me to work and to live, because you have proximity to lots of other great cities as well. That image on the left is of Firth Court, which is one of the main buildings at the University of Sheffield, where the sort of Vice-Chancellor and the Vice Presidents have their offices. So the University of Sheffield is part of the Russell Group of universities, and that's a group of 24 of the top UK universities who are very high impact and very well known for the quality, the amount and the impact of the research that they do, as well as offering outstanding learning and teaching. And our research is sort of monitored and measured by a thing called the Research Excellence Framework in the UK. So all research active universities every 4 or 5 years go through a process of having their research evaluated to see how the quality of it, the impact of it, how it compares with other institutions that are doing research in the same kinds of areas. And SHAR was ranked 4th in the UK for the power of our health research, and top 6 for the volume of research that we produce. So we are a very research orientated and research active department, and all of that feeds into the courses and the teaching that we offer. In terms of our rankings, through the QS World University rankings, we're ranked 78th in the world and 13th in the UK overall as a university. We're 117th in the world and 14th in the UK in the Times Higher University rankings. And we're also in the top 100 most international universities in the world. So that reflects the diversity of our student base, as well as the sort of international nature of our research and so on. So SHAR, the School of Health and Related Research, is a department within the Faculty of Medicine, Dentistry and Health. And SHAR is a very, very big department. It's actually the largest department at the University of Sheffield. And because of that, it's organised into 4 different sections. And those are Health Economics and Decision Science, Health Services Research, Design, Trials and Statistics, and Public Health. All of the staff in those 4 sections all contribute to the different master's programs that we offer. But I think that probably seeing those sections probably gives you a sense of the breadth of what we do in SHAR and the range of expertise that we have. So SHAR was ranked in the top 3 UK universities for research impact within the area of health services research in the last Research Excellence Framework. We're involved in a wide range of research activity for lots of different funders and organisations. So we do research that's funded by UK research councils, international charities, the National Institute for Health Research in the UK, and the National Institute for Excellence in Health and Social Care in the UK as well. But we also do consultancy work with the healthcare industry and the pharmaceutical industry. So the research that we do and the kind of knowledge exchange activities that we're involved in are both sort of within the UK and internationally. And we're known both for the research that we produce, but also methodological work. So what that means is that as well as producing research for various funders, we also do work about how research is done and improving research methods and how research methods can adapt to become, better, more reliable, to produce results that are closer to the truth. So our kind of research activity is both in terms of producing research, but also doing methodological research. In terms of being a student with us at SHAR, you benefit from that research environment by being taught by people who are at the forefront of their disciplines, who are at the forefront of innovation and very up to date in their knowledge within their discipline. And staff who also have sort of wide networks in terms of the other researchers in the institutions that they have links with. But we also offer a range of support to our students. that covers all kinds of aspects of your student support and the support you might need during your time at SHA. So you'll have a personal tutor. So that's a person allocated to you who you can go to with pretty much any kind of query or concern that you have. Every module that you study as part of your program will have a module tutor who you can contact with questions about the module, the assignments, and so on and so forth. Our course administrators are there to help you if you ever need help with paying fees, with the application process, getting an extension on an assignment, all that kind of thing. We have learning technologists who help to support the virtual learning environment that we use to deliver some of the teaching materials that are part of our courses. Our careers service are fantastic. Over the last year, they've really worked hard to provide exactly the same service online as they normally provided in person. But we have a fantastic careers service who work with our students from the absolute beginning. So in intro week, before you've even started your course, our careers service start working with you on career planning to encourage you to be thinking right from the beginning and over the year that you'll probably be studying with us about how you can be getting involved with careers activities, arranging interviews and thinking about where you want your career to go once you've finished your program at SHA. And as well as those kind of forms of pastoral support, you'll have access to a vast range of electronic resources in terms of databases, electronic books, and so on and so forth, as well as the traditional university libraries. There is support with academic aspects of your course as well. So if you have any support needs in terms of academic writing, with maths and statistics, or with English language, we have support available to cover all of those things. All of our students at SHA get English language support in their first semester, including our students who have English as a first language, because we use the English Language Teaching Centre to also deliver study skills, just to get you up and running with your course and get you used to writing in a way that is required in UK universities, helping you to become familiar with the writing style that we use, with academic practice in terms of using source material, producing bibliographies and reference lists and things like that. So we have a lot of support, and we really pride ourselves at Sheffield and at SHA on being very supportive of our students to help them do the best they can. In terms of the career opportunities, there's global opportunities in national and local government and ministries of health. Some of our students go on to work or further study in universities and research institutes. Some go on to work in non-governmental organisations and charities, and also there's opportunities within the pharmaceutical industry as well. Within the UK, there's opportunities with Public Health England, with the NHS clinical commissioning groups and NHS Foundation trusts, and with the National Institute for Excellence in Health and Social Care and the National Institute for Health Research. Because we offer quite a broad range of courses, our graduates go on to all kinds of careers. But in terms of our Masters in Public Health programmes, very much our graduates are likely to go on to work in national and local government, within ministries of health, and particularly within NGOs and charities as well. And the majority of our graduates do go on to full or part-time employment as soon as they finish their course. So, as I've said, a majority of our graduates go on to full or part-time employment. Some go on to further study or a combination of work and study. And there are opportunities, if you're interested in PhD level, to stay at SHA after a master's programme and progress on to PhD. We have some funding opportunities for that in some areas and for some courses. So if you are interested in an academic career, there are opportunities to carry on studying with us to do a research-based degree. In terms of what we require a 2:1 honours degree or a medical degree, probably in an area related to health or healthcare or biological sciences, or potentially a maths and statistics kind of background for our health economics courses, or potentially a management background for our health management courses. We can be quite flexible about the subject of your first degree. We do require you to have an English language qualification, so that means having an IELTS or equivalent qualification with an overall score of 6.5 and at least 6 in each component. But we are now accepting a slightly wider range of English language qualifications, and some of the online tests that are available are now acceptable. So you can find out more about those at that link. But do investigate our course pages for our specific courses, because there'll be information there about the specific requirements and any flexibility in the requirements for individual courses. So that's it from me. Like I say, if you want to talk one-to-one with me and Hannah on Saturday, book an appointment to come and have a chat with us, and we can talk about specific aspects of each of the courses and which one might be right for you, or talk about coming to Sheffield, the university, what it's like living and studying in Sheffield. So do book one of those appointments if you want to, or you can use the email address on the screen, particularly after Saturday, for any kind of follow-up inquiries. But I'll stop my screen share now and hand over to Dr. Sam Catton, who's going to deliver the lecture on public health.
Sorry about this. I couldn't get the controls for Zoom and share my screen, so I'll try sharing again now. So, here we are. Can everybody see these slides okay?
I can see that, Sam.
Yeah, lovely. Thanks, Claire. So my name's Dr. Sam Catton. I'm a senior lecturer in public health in SHAR at the University of Sheffield. Before I start, I should also add that I did the Masters in Human Nutrition at Sheffield. So I'm a psychologist by first degree, and then I did the Masters in Human Nutrition. So I'm a psychologist and nutritionist with a background in public health. So a lot of my work's on eating behaviours and obesity in various different populations. However, I'm not going to talk to you about that today. That's for another talk that you could possibly come and listen in if you follow SHAR Public Health on Twitter. Today I'm going to give you an introduction to public health and a taster of the sorts of lectures that you'll receive, if you choose to come to SHAR to do your master's degree. So the aim of this session is to briefly describe what we actually mean by public health, explore some of the key concepts associated with public health. So to give you a general flavour of the types of things that, from a public health perspective, we're interested in looking at, such as factors that may cause ill health in populations. And then we'll cover what we call the 3 domains or 3 pillars of public health that give you a little bit of a further understanding about what public health actually is. So first of all, I'm going to show you 3 figures. I have asked people to maybe put in the chat function any thoughts that they're having. So feel free to do this if you're feeling brave. If not, then I'll just move on when we get to those questions. So 3 figures, 3 graphs. So this is a life expectancy at birth figure from the King's Fund. And what you can see here, so this is data from England. So we've got across the x-axis dates from the year 2000 up to 2019. And basically the point here is what we're seeing is an increase in life expectancy. Yeah, so as time's gone on, we're seeing this linear increase of life expectancy in males and females. The difference between males and females, that remains true, but the point is that it's increasing over time. And again, if we look at countries such as Japan, You know, we're seeing a similar kind of trend. So again, a linear increase in life expectancy, again, seeing those differences still between males and females. So something is happening over time. The third graph that I'm showing you, so this is quite a complicated one, but it still makes quite a similar point. So across the x-axis is income, across the y-axis is lifespan, so life expectancy in years, and you'll see across the top axis, the top x-axis is income level, so it's split into categories. So we've got income level 1s, 2, 3 and 4. And you'll see here on the bottom right of the figure that each individual country is coded. Yeah, so we've got the African countries in blue, so on and so forth. Again, what we see here is a linear increase. So the more affluent people are, the longer they live. And you'll see that actually, according to national income levels or national wealth, that we're seeing a clustering of the different countries. So right up at the top, we see a clustering of yellow countries, and then moving down into green. Interestingly, the countries coloured in red are quite dispersed throughout this, but then you'll see a clustering of the African countries down at the bottom. Yeah, so people who are wealthier from richer nations are living longer. Yeah, so we're living longer over time. So something's happening within the country at the country level. And then when we look at particularly with regards to income and lifespan, you know, we can see that something's going on there as well. So we won't spend a few minutes doing this. We'll just have a brief thought considering the following. So why do we live twice as long as we used to? Because actually, if we'd have looked at those figures from the UK and indeed Japan going back, you know, over the last 100 years, you know, we would have seen this increase over time. So what's actually been going on that makes us live longer? Yeah. And then related to the second figure that I showed you, why do we live twice as long as people in lower income countries or developing countries as they used to be known? You know, again, what's going on there? So people are probably sat there thinking, well, there's a number of factors that might determine these. And these are the sorts of things that we're interested in looking at. So things such as access to healthcare, vaccinations, which of course is very, very important nowadays with COVID-19. You know, and COVID-19's been labelled certainly in the UK as a pandemic of inequalities, you know, where we're seeing people who are less affluent being more affected by the pandemic. And again, at a global level, we're seeing access to vaccination programs. We're seeing huge disparities between the wealth of countries and access to the COVID-19 vaccine. Other factors that are governing why we live longer are things such as improved treatment and diagnostics at the medical level, improved sanitation, nutrition, even things such as improved working conditions. You know, we would like to think that actually the working conditions that people have nowadays are not those resembling what we used to see in Victorian eras. And then things such as poverty. Obviously, we saw that in the figure that, you know, the poorer that people are, the less likely, the less likely they are to live as long as more affluent people. Things such as poor education, you know, this translates into health outcomes as well, because, you know, health education, how do people understand constructs and surrounding health? You know, this feeds on into, you know, improved access to healthcare as well. So health literacy. Things such as poor quality housing, pollution, the list goes on. I'm sure that some of you have been sat there thinking some of these things that I'm talking about now. So these are all the things that we think about in public health. So this brings us on to the formal definition of what exactly is public health. So the UK Faculty of Public Health have this really nice definition here. So it's the science and the art of promoting and protecting health and well-being preventing ill health and prolonging life through the organised efforts of society. So there's lots and lots in this formal definition. So the science refers to the fact that in public health, everything is evidence-based. You know, we don't do things just because they feel like a good idea. We do things because we utilise the evidence that's there, the best available evidence moving forward. The art part of it might sound quite odd to some people, but the art part refers to the fact that, you know, public health and the management of public health conditions is an ongoing process, and we constantly need to review them and reappraise things and change the way that we do things, you know, moving forward to find the best solutions. And actually, sometimes, or should I say all of the time actually, in science and public health, you do have to be quite creative. Yeah, so that's the science and the art of health promotion, disease prevention, and all of these things. So public health takes what we refer to as a population perspective. So when I teach public health on the medical degree, I always use the stream analogy. Yeah, so medical doctors deal with individuals. So medical doctors deal with, you know, individuals that have fallen into the stream. They pull them out and they make them better again. Whereas public health acts what we call upstream, and public health finds the cause of why people have fallen into that stream in the first place. Yeah, so public health aims to stop disease states, stop health problems from happening, whereas medical doctors who take a more individual approach to health, you know, they look at the solutions to people's health problems. So we're all, public health is about preventing ill health. So this is a really quite well-known diagram that if you come to Sheffield or indeed any other public health degree programme, you'll see this figure lots and lots and lots, and it'll keep cropping up in many, many different contexts. So this is the diagram by Dahlgren and Whitehead. And this was produced in 1991. There was other diagrams similar to this before this, but this is actually the most effective, and it's hung around for all these years. And this diagram actually describes the wider determinants of health. And this is another key concept that you keep coming back to in public health. So the wider determinants of health are a diverse range of social and economic, environmental factors that influence people's mental and physical health. So I should point out here that a lot of people think that public health just deals with people's physical health, and that's not true. There's a huge focus, especially nowadays, on people's mental health as well as the physical health, because we know that the two absolutely interact, and actually we should be paying attention to both, and indeed we are. So this diagram highlights to us another key concept, what we refer to as health inequalities. And the results of inequalities in these determinants of health. So if we just look at the diagram and consider some of the things here. So you'll see at the in the middle of the diagram that we've got the individual. Yeah, and I always say to the medical students, this is where you tend to focus, but actually you need to start looking outward for the diagram. So in the middle, we've got factors such as age and sex. And from a psychological perspective, these were what we call non-modifiable factors in changing behaviour, because, you know, we can't change people's biological sex, which predisposes them to certain diseases. We can't change people's age. Unfortunately, we can't stop the aging process. So these are non-modifiable. But as we go out from the middle of this diagram to think about the social and community networks, so this, in a general, very broad sense, refers to how embedded within their communities are people. You know, what social support systems have they got going there? How do they feel empowered as an individual to take control over their lives and indeed their health? And then if you look at the factors that are in green, so we've got agriculture and food production, you know, this is a huge part, and it tends to be where a lot of my work focuses on, you know, what foods are being produced, what access to foods do people have, you know, can they afford access to good food? Quite often with populations that have got non-communicable diseases such as type 2 diabetes, cardiovascular disease, you know, this is one of the things that we're looking at. You know, because we know that there's a social gradient in health where people who are less affluent are more likely to have some of these non-communicable diseases. Another factor that's really, really important is education. You know, again, I spoke very briefly earlier on about health literacy. You know, how do people interpret information around their health? And of course, that differs between individuals and indeed populations and countries and so on and so forth. We've got the working environment, the conditions in which people work, and then things such as employment rates, you know, whether or not an individual's employed or unemployed will impact upon their health. You know, this might also impact upon access to good sanitation if we're thinking about global public health, which of course is another key focus of SHA. We have a wonderful global public health team. Healthcare, access to healthcare services, we'll come back to that one because that's really, really quite important at a local and a global level. And then things such as housing. If people don't have good quality housing, you know, this will impact upon their health. So for example, you know, if people are living in housing conditions which are really poor, where it's particularly cold, you know, you might then get things such as mold growing in the house that impacts upon an individual's respiratory health, so on and so forth. So hopefully you'll see from this very brief introduction to this diagram that actually some of the biggest determinants of health reside outside the individual. You know, we can always come back to medicine and solve the problem with medication, but actually, you know, we've discovered a lot of solutions at that level in terms of health and medicines and pharmacological interventions. A lot of the low-hung fruit have already been picked there, and actually we need to be branching out and looking at the reasons why people become ill in the first place. So moving on, we've got two case studies here. Yeah, so two quite interesting case studies that should highlight what public health is all about and what we're interested in. So here on the left hand panel, we've got the case study of Maria. So Maria is a 3-year-old girl with asthma. Yeah, so she lives in Parsons Cross in a 3-bedroom house. So just to digress a little bit, so Parsons Cross in Sheffield is one of the less affluent areas of the city. Her parents are from Romania and have been living in England for 3 years. Her father has just found employment as a waste collector, and her mother looks after the children, and she's got 4 siblings. Yeah, so we've got lots of people living in a 3-bedroomed house, individuals that have come to live in the UK from, you know, a different country with very, very different health systems. English isn't their first language, you know, so that's the scene setting for Maria. Whereas Stephanie in the right-hand panel, on the other hand, is also 3, and she's also got an asthma diagnosis. But Stephanie is the only child who lives with both of her parents indoor, which is a very, very wonderful place in Sheffield. It's close to the Peak District. It's the sort of place that you aspire to go and live in because it's so nice. And they live in a 4-bedroom house. Her grandparents live just 2 roads away, so they've got lots of support there. Her father is a finance director and her mother is a doctor. Yeah, so 2 very, very different cases here, both for 3-year-old children. The sorts of questions that we're interested in public health is to answer things such as, so who's more likely to end up in hospital with their asthma? Who's more likely to get good medical follow-up after this hospitalisation? And I suppose the big questions here for public health is, why is this happening? You know, and then how can we change it? because if we don't know the answers to these questions, then we're not going to be effective in doing anything. So this is the exploratory nature that we take in public health to solve these sorts of problems. So we can consider the following. I won't ask you to put it in the chat function at the moment. So why might one girl more likely to have problems in managing her asthma compared to the other? Yeah, so we're thinking about all of the different things that, you know, in the case study. So we've got one girl living in a more deprived area, a poor area of Sheffield, that's more likely to be highly populated. They're living in a highly populated house. Her parents, you know, their English might be successful in varying degrees here. You know, they've come from a different background where the health system's very different, you know. So whereas compared to Stephanie, you know, her mum's a doctor, her mum's a general practitioner. There's lots of social support there. They live in a very rural, beautiful area, lots of access to green space for exercise, where it's safe, you know. So I think that the cases are telling us actually, you know, Stephanie's going to have a better outcome in terms of managing her asthma compared to Maria. And why might this be? So this is the why question. This is one of the really, you know, interesting and important questions that we need to ask. So what we do in public health is we think about causative factors. You know, why is this happening? What's causing it to happen? And then we think about barriers to action. So what are the barriers that maybe the patient has to overcome, or in terms of the health system, what do we need to do about it? So we'll focus first of all on potential causative factors, and these can be split into biological predispositions, or they can be split into things such as environmental or occupational factors. So I'm not going to go through all of these. We'd be here for well over an hour if we were to explore these. So biological predispositions for Maria versus Stephanie. So Maria is more likely to have a lower immune response. So, you know, there's a good chance here, just purely from the demographic variables that we've looked at, that she's going to have poorer nutrition. You know, food insecurity is more likely to be worse in Maria's case compared to Stephanie. Yeah, so we know that food insecurity is related to worse nutrition, which in turn has an impact upon people's immune responses. She's more likely to have been born premature, and this might be due to maternal smoking factors or other family members smoking, and we'll come on to that in the next diagram. She's less likely to have been vaccinated from childhood illnesses. And this is purely because, you know, Maria's parents may not understand the health system. You know, that they don't understand what's going on. The vaccination schedules are likely to have been different. It's all very, very confusing for people that are coming from outside the UK into the UK. Environmental or occupation factors. So, you know, Maria's more likely to be exposed to cigarette smoke if the family members are smoking. And again, this has got a lot to do with health literacy and actually the stress conditions in which people live. When people don't have as much expendable income or indeed have any expendable income. Maybe more exposed to things such as pollution, you know, living in a more densely populated area. As I mentioned earlier, the importance of housing. You know, Maria's more likely to live in a damp and crowded house, more likely to live near a main road, again, linking back to exposure to pollution. Potential barriers to action. So access to healthcare. You know, Maria's got more siblings, so, you know, it might be more difficult for a mother to actually get her to the general practitioner, you know, taking all of these children on a bus or just finding the time to do that. Less likely to own a car, related to that issue as well. You know, even less likely to be registered with the GP. You know, that we know that there are cases out there where certain populations have not registered with a general practitioner when they move over into the UK because they simply don't know how. They've never encountered anybody that's facilitated this process. So this can be a huge problem. In terms of education, health education, you know, Maria's mother might be less likely to recognise the problem. If Maria's given medication to manage her asthma, you know, she might be less likely to understand, you know, how the medication works, you know, the dosing instructions, the rationale around treatment of asthma as well. So these are some of the questions that we ask and some of the things that we attend to in public health. So individually and collectively, all of these are really, really quite important. Another way of looking at it is to produce a driver diagram. So this, you know, splits certain sorts of behaviours into categories, and you can actually apply a timeline of how important these things are. So we've got Maria has bad asthma here on the left and several different factors. She doesn't come to the asthmatic clinic. Why doesn't she come to the clinic? Because her mother has no transport. Her mother has other children to look at, as I've just mentioned, look after, as I just mentioned. And, you know, it might be the case that a mother can't read or understand the, you know, the appointment letter, and so these simply get ignored. Maria doesn't take the prescribed medication. You know, at a global level, not particularly in the UK because children are given free access to prescriptions, but if we want to apply this to different countries where people have to pay for children's medications, the parents can't afford them, yeah? You know, it's simply not a priority for the parents. You know, the number one concern is probably to pay the rent on the house, pay the bills and feed the children. A second problem related to medication is that parents don't know which one to use or how to use them. You know, maybe they've not understood this very well. They've not, you know, been able to ask the right questions at the time of prescribing these medications. And then further down, you know, her father and her grandmother smoke, so there's lots of exposure to smoke here. You know, that the father smokes around the children and he simply doesn't know that this is harmful. The father would like to smoke, would like to stop smoking, but nobody's actually told him about smoking cessation services, and so on and so forth. So you can really get into the crux of all of these behaviours and issues that you need to tackle. And this brings us on to another really, really important concept in public health, and this is the inverse care law. So this was coined by Dr. Julian Tudor Hart back in the early 70s, and it's one that's very much still at the forefront of what we do. So the official definition provided by Tudor Hart is the availability of good medical care tends to vary inversely with the need for it in the population served. This operates more completely where medical care is most exposed to market forces and less so where such exposure is reduced. So to simplify this, we've got this figure here. And basically, the inverse care law describes how those with most need get the lowest level of access to services. Yeah. So those populations, such as Maria's family, are less likely to access healthcare compared to Stephanie's family. Yeah. So Stephanie's family, her mum's a doctor, she'll have lots of connections within the medical field. You know, she probably gets priority for appointments. She knows exactly what questions to ask. And this holds true for a lot of people that fall within the most affluent proportions of society. You know, we're all very good at navigating the NHS system, so medical care in the UK, whereas individuals who are less health literate, less affluent, have got other things going on in life, tend to access the services less. Yeah. So one of the main focuses again on public health is, you know, what do we do about this? You know, the NHS is supposed to exist in England and it's free for all. And there's very much an assumption that, you know, this is an equitable system, but it's actually not, because the more affluent people who need the system less are accessing the services more. So this poses a massive challenge in public health. Moving on to the 3 domains of public health. So what is public health? So very briefly, it falls into 3 main categories. So we've got health promotion or health improvement. So this looks at things such as inequalities, education, housing, employment, lifestyle factors, you know, surveillance and monitoring of specific disease and risk factors. The second one is health protection. Quite important nowadays, so looking at infectious diseases, environmental health hazards such as exposure to radiation, chemicals and poisons, and it also lends itself to looking at emergency responses. Then the third domain or third pillar of public health is with regard to improving health services or improving access to healthcare services. And so this looks at the clinical effectiveness. So how good are these services? You know, how effective are they at reducing particular disease states? The service planning, audit and evaluation is included in this, clinical governance and equity, as I just mentioned, as it lends itself to the inverse care law. You know, how equitable are systems for the population as a whole? Just to contextualize this and thinking about Maria and Stephanie, so health promotion, health improvement. So you remember on a couple of those diagrams, you know, we talked about how important it is to get family members, Maria's family members, to stop smoking. You know, so under the pillar of health promotion and health improvement, we'll have things such as smoking cessation services, so behavioural management of smoking, looking at social drivers that actually enable this behaviour. And so an example of this has been the shift to banning smoking in public places, encouraging smoke-free homes, covering up cigarette packages in shops. In the UK, whenever you go into a shop that sells cigarettes, they're always behind a blank screen nowadays. So when you walk into the shop, you don't actually physically see the cigarettes. You know, these cabinets or curtains are only lifted when people actually were asked to buy them. Things such as improving health literacy, health education about particular conditions and certain lifestyle choices, improving social links within the community, and also, you know, there's lots and lots of work on improving housing as well. Health protection, so one key thing here is reducing transmission of infections. So all of the things that I talked about, so childhood immunisation, the treatment of transmissible diseases, monitoring new infection rates for new outbreaks. Of course, all of this stuff is really, really important in the current climate as well. And then improving services. You know, so actually we need to think about this evidence-based approach that I mentioned right at the beginning of my talk. You know, what is the best way to actually treat asthma? You know, what's the best way to treat paediatric asthma? And for this, you know, we need to start considering things such as NICE guidelines, local guidance. You know, what is the quality of services? You know, how well, you know, are we delivering a service? How well are people accessing the service? Do people feel that they're getting, you know, good service from healthcare providers? And then related to this, accessibility of services. So I've spoken quite a lot about this. You know, how well do people, are they able to access, you know, the services on offer? And then the final part of this is health economics. So we have a wonderful team of people that deal with health economics in SHA. You know, and you know, we need to think about how much does treatment cost? Is it worthwhile? You know, putting things, you know, making things available, treatments available for individuals. You know, what is the best way ultimately to spend the money to improve health? Yeah, so what are the most effective treatments for particular disease states? So I've briefly summarised what we mean by public health. We've explored some key concepts that you touch upon in public health, and hopefully you all feel slightly more familiar with the three domains or the three pillars of public health. So if anybody's got any questions, please do bob them in the chat. Claire or myself would be happy to answer these as well.
Thank you very much for your presentation, Claire and Sam. Already we have the questions. 学士課程コースの出願に必要な IELTS のスコアは何ですか? What is the IELTS course for UG undergraduate level? I don't know who's going to answer this.
Hi, sorry, so the question's about IELTS.
IELTS score, yeah.
For our courses in SHA, you have to have an IELTS of 6.5, or there are other qualifications that we accept. Or if you have recently done, in the last 3 years, you've done a degree that was taught in English, then that can usually be counted instead of an English language qualification. But to do any of our courses, you need 6.5 as your overall score, and then at least 6 in each of the 4 components that make up the IELTS test.
Thank you. 今回答がありましたように、まずは 6.5 ですね、必要になってきますので、頑張ってみてください。Second question ですね。2021年度入学のための出願の締め切りいつですか? When will it be the deadline for 2021 intake?
Sorry, did you say the deadline?
Deadline, the application deadline, yes.
I think it's the 12th of September this year. We do try and be a little bit flexible, but that's the absolute kind of last point at which you could possibly apply. Obviously, if you're traveling to the UK, you need to think much earlier than that, and you can apply using the online application form at any point. So when you start to apply for one of our programs, you use the online application form, and you can keep saving your application without submitting it. So we can't see it yet until you're ready and you have all the documentation uploaded that you need. And then you can finally choose to submit your application. Or if you change your mind, you can just delete it and not proceed. But the sooner you apply, the better, really, obviously, in terms of getting a decision. And also, if obviously there was any additional information that you needed, or if you needed to take an IELTS test to sometimes have a more up-to-date one, then you're allowing yourself time for that. I think typically on our MPH program, we see most of the applications for students who will ultimately start the program, particularly from our international students. Many of them have already applied by now, and certainly sort of by the end of April or so, the majority of the students who will ultimately come to Sheffield have probably already submitted their application. So the earlier, the better, I would say, because like I say, applying and being made an offer doesn't mean that you don't have to accept immediately. You don't have to make a decision right now about whether you are going to accept the offer and whether you are going to come to Sheffield. But the earlier you apply, then the more time you have, obviously, to, like I say, to finish your application and make your decision about where you want to go. So putting in an application doesn't commit you to coming to Sheffield. And like I say, you don't have to decide now. Even if you get an offer very quickly, you don't have to accept the offer immediately. You can take your time to think about what you want to do. So I would say, in terms of applying, the sooner the better, really. And like I say, consider starting an application and taking your time over it. You don't have to just sit and do it and submit it in one go. You can start an application now, save it, and like I say, we won't see it until the point at which you actually submit the application. So you can start working on an application, obviously have a look at the form and think about the information that you're going to need to provide and the documentation you're going to need to provide, and obviously start sorting all of that out as well, because obviously for some people it might take a while to find their degree certificates, their transcript, their IELTS, or whatever other documents you might need, or getting references obviously from employers and previous academic institutions.
Thank you very much for your clear explanation.
Is it okay if I sorry,
okay, yes, please.
Hello, konnichiwa, konbanwa. I could just add something here, just to what Claire said. The university does have some scholarships as well for this September's entry. So Japanese students who are looking to apply for September, if they want to be considered for a scholarship, postgraduate scholarship worth up to 25% of the tuition fee, then they would have to have applied and already have an offer and then apply for the scholarship by the 17th of May. So that's quite a good reason to apply early, definitely, if you want to be considered for a scholarship. There's also an accommodation guarantee. So students who want to join university accommodation must apply for this by the end of August, and then they will be guaranteed accommodation. And also, if students need to improve their IELTS score, there is an option to join a pre-sessional English course in the university, and they run over the summer. So depending on the IELTS score, there are courses of different lengths to suit different scores. So obviously that means that they need to have an offer early to then join the pre-sessional course. So just as definitely, as Claire said, the sooner the better. And if students have particular questions, they can get in touch and we can discuss those after this. Thank you.
Thank you very much. 結論から言うと、早く出した方がいいということになりますけれども、一般的には、9月の、初旬まで、アプリケーションを受け付けてますよということでしたが、奨学金ですね、が、授業料の25% という奨学金がありますので、それとかも、応募ご希望ということでしたら、早めに5月17日までに、なるべく早く出せるように、ご準備いただければと思います。あと、アコモデーションの、保証とかもありますので、次々ですね、合格が出て後の、手続きをスムーズにするためにも早く、ご出願をお願いいたします。じゃあ、次の質問に参りますね。Next question。パブリックヘルスの、ごめんなさい。コースの学生の平均年齢はいくつですかということで、What is the average of students' age in public health course?
Hi, on our Masters in Public Health course, we do get quite a wide range of students because we do also have some part-time students on some routes of our course. But I would say the majority of our students are probably in their 20s to early 30s, so probably between sort of 21 and 35, something like that.
Thank you. そうですね。今のお話ですと、20代の方もいらっしゃいますし、30代前半の方もいらっしゃるということなので、21歳くらいから35歳ぐらいまでということでしたね。はい。それでは次の質問に行きます。I have 2 years of working experience in nursing. Can I apply for postgraduate course?
It would depend on how you did your nursing qualification, but in all likelihood, I would imagine you probably did some kind of degree qualification. You do generally need a first degree of some kind. So if you did a degree to qualify in nursing, then that plus obviously the experience that you have would be very useful in terms of your application. Having practical work experience within a health background is really useful and advantageous on a course in public health. But the best thing to do is to, if you put in your application, as program leaders within the department, we're able to discuss with our central admissions department. If there's any question mark about whether your background in your first degree is suitable, they'll get in contact with us to ask, you know, the program leaders in SHAR whether we think that your qualifications and your experience are suitable. But generally speaking, you do need an undergraduate degree to apply for our master's program. So if you did an undergraduate degree or even a postgraduate degree to qualify in nursing, then that would be a suitable background for public health.
Thank you. 個人個人で、ケースバイケースっていうことではありますけれども、まず、学部で、卒業されていて、で、看護資格として、お持ちで、実践として働いているのであれば、入れる可能性があるということですね。ですけれども、詳しいことを聞きたい場合には、実際に、お問い合わせをしてみた方がいいということでした。はい。それでは、次の質問に参ります。パブリックヘルス保持者のイギリスでの平均収入はいくらでしょうかということですね。What is the average income of public health graduates in the UK?
I'm afraid I couldn't really answer that one because it depends entirely on what career area you go into. I think generally speaking, if you go into the private sector, so that would be working in healthcare consultancy, which some graduates do, or working within the pharmaceutical industry, then earnings are certainly higher there than if you work certainly in the UK in the public sector. And obviously it depends what kind of level you're working at. So no, I don't think I could give a sort of an average, but certainly working in the private sector, you can certainly get a much higher salary there. It's a more lucrative area to be working in. And on our health economics programs and on our MPH program, we do have graduates that go on to work in healthcare consultancy, and that is quite an expanding area in terms of employment.
はっきりとちょっとここでは申し上げることができないということでしたが、製薬会社とか、分野によっては、給料が、収入がですね、高い場合もあるということでしたので、会社にもよるでしょうし、機関にもよるということになります。他に何かご質問ございますでしょうか。Thank you very much, dear. I read through all the questions. またですね、後ほど質問等ございましたら、フェアもございますので、ぜひお越しいただければと思います。それでは本日ありがとうごめんなさい、はい、Thank you, Claire. 今ですね、先ほどの出願のデッドラインについての話でしたけれども、今チェックをしてくれまして、9月10日だそうですので、9月10日まで出していただけることが可能だそうです。ただ、先ほどもお伝えしました通りに、寮だとか、ビザだとか、そういったことを、その後しなければなりませんので、早いご出願をお勧めしますということでした。はい。それでは本日皆様ありがとうございました。これで終了させていただきます。Thank you very much for participating in the seminars. Thank you, Claire. Thank you, Sam. Thank you, Hannah. Everybody. Thank you.
Thanks, everyone. Bye.
Thank you.
Thank you. Bye.